I'm Matt Fidel. You guys are lucky enough to hear me for the next 2 hours. Unfortunately, it's right before you leave for the day, so I'll try to be quick and please, throughout the discussion, interrupt me as much as possible. Ask questions. Don't wait until the end. Happy to go through this with you. I've worked for about 75 different health systems across the country. Depends on each market that you're in, depends on each state that you're in. Certainly the strategies from the physicians that I interact with to the health systems that I interact with on a daily basis are different based on their markets. I'm from Cleveland, Ohio, a very self-deprecating Cleveland Browns fan. And then I got into healthcare because it's a challenging, very challenging industry, as well as it's very rewarding. I made the mistake of, in a group of health system executives and physicians, saying actually the challenge is fun, and the response I got was, I'm working harder, getting paid less, I don't consider that fun, help me out here. So I've changed that, and I don't use the word fun anymore. But as you can see, I work a lot with clinically integrated networks. I find ways for health systems and physicians to work more collaboratively together, and then work on changing behavior from that. A lot of the behavior that I see changes in the most are when you align incentives to best incorporate all parties and a win for all parties. If the incentives aren't aligned, you're not going to see, or at least you're not going to maximize the change that you're looking for. So certainly that's a big aspect of what I do and how I do it. SG2, if none of you have heard of this organization, you're seeing two examples of just knowledge, intel that we do have. It's a membership model with analytics and then consulting on the end. I'm part of the consulting firm that works with different health systems and certainly physician groups on problems that they occur and help them with solutions as well. Today, the first hour, we're going to be going through what is clinical integration, and then how do you optimize performance within your clinical integrated network, accountable care organization. We'll go through the list of different acronyms that are being used. That's really just semantics in terms of how our health systems and physicians working more collaboratively together, and then how are the providers being rewarded for that change. And then we'll take a quick break, and then we'll get into the market forces impacting value-based contracting, certainly the maturity of value-based contract strategies, and then the contracting case studies. I have case studies throughout this. LinkedIn, feel free to ask any questions throughout. Happy to share that. So the first thing I'm going to be talking about is in 2019, we're really breaking down boundaries. So the challenge, they're challenging how you get paid and earn a margin, right? Drive and measure growth, meet customers on their terms, innovate a complex organization. Everybody knows healthcare is very complex. Reconfigure and define your footprint. So we've heard this term value or volume to value over and over again. Well, it's now volume to value back to volume. The for-profits that I'm working with a lot are driving volume. They're pushing it. They want that, and certainly a quality to them is a prerequisite. The not-for-profits, they're taking on both the volume approach, but also, making sure that the outcomes are more there, and then publicly available data supports the data that they're giving. Certainly, there are different strategies depending on who you're interacting with and what market you're interacting in, but that's what I'm seeing, at least at a very high level. So, right now, the external pressures continue to push adoption of this value-based care. You're seeing dramatic stakeholder consolidation. Widening gap of the inpatient to the outpatient that has been discussed a little bit over the last few hours here. Increased data access and analytics. That's being certainly a major aspect of a lot of the health systems, and health systems and providers are spending a lot of money on analytics and not getting as much value from those analytic sources, or at least not getting the data to the right place at the right time to make a really big shift in what they're doing. Rising healthcare costs and margin pressure, we'll get into that in terms of how that's interacting and changing the way we're providing care. Rising consumerism. I read a study the other day that actually said that the highest priority for a patient when they're selecting their provider is not quality, is not cost, it's convenience. And certainly that's changing the way that the providers are interacting with their patients, and it's a priority. You'd think that with the transparency of cost that it's out there, and people are reviewing that on a daily basis. Consumers are reviewing how much it costs. It's not happening at a rate that we would all have expected, unfortunately. And then high deductible plans, again, we'll get into that a little bit later, are actually driving people to select not to go to the physician as much as we'd want them, or at least hope that they would be. So there's innovations, there's strategies going on in healthcare. Some are working, some aren't working. We'll get into some of those aspects and how that is changing the way patients and providers are interacting on a daily basis. Certainly the provider shortages are accelerating. That's creating ways of interacting more with different kinds of providers, maybe not even in the healthcare sector, right? We're looking at hospitals and health systems working with transportation, working with the county, certainly other aspects, and that's having a significant impact on quality. So it's not just the physicians that are driving it, but it's the overall consumer or the overall community that's changing that as well. Again, that we can debate where the incentives are being driven. We can debate who is having the biggest impact on the patients, but certainly there are innovative ways being created to drive quality and to drive affordable costs of healthcare. And then evolving advanced alternative payment models. We've heard APMs stated in the past over the last 2 hours, and I'm sure everybody in this room has everybody in this room heard the term alternative payment model at least once? Great. Okay, so we'll talk a little bit about that, and some of those are working, some of those aren't working. And the ones that aren't working are being changed on a yearly basis. Medicare's changing them, adopting them. And then the managed care, the commercial payers, are adopting the ones that are working. And so that's a very, very important point and something that we'll go into as well. So right now, no one's staying in their lane in healthcare. Everybody's getting out of it. You're seeing insurers purchasing health systems. You're seeing health systems creating or purchasing insurers. You're seeing providers being purchased, again, by insurers. And then you're seeing CVS, Walmart. Everybody's getting into it. Amazon is now starting to get into it. So it's not the same old folks that are driving quality, or at least trying to get into this. Hey, healthcare costs are rising at a rate that can't continue. There's a lot of disruption in the industry, and something that we all just need to be sensitive to. This is a slide that SG2 created a number of years ago. You might remember it if you've seen it. On the left, you can see the community-based aspect. The line in the middle articulates acuity. So in the lower acuity area, the community-based providers, primary care, as well as how's virtual health kind of implementing within that. And then as you go up the orange line, that's really following the acuity and understanding, how do you distribute your services appropriately as you're making that rise, and then how are you aligning with your providers, or at least your post-acute providers that you may not own, but certainly drive your bottom line at a significant level. Just something to be cognizant of. And then looking at this from the patient's perspective, right? Healthcare could be a very stressful and confusing experience for patients, and so it's really changing to adapt that that convenience is a major player in the patient selection process. The training wheels are off. Right now, you're seeing Medicare drive this, and you are seeing commercials drive you and your organizations more to downside risk. That's something that they want to push. Some may say it's a race to the bottom. Others may say it's taking accountability for the outcomes that you're providing to your patients, and then hoping that they in turn take accountability in and of themselves. to take better care of themselves. Certainly there's a push-pull there that's going on that we can all be sensitive to. And then really balancing that portfolio. Your organizations, if you've been practicing more than 5, 6, 7 years, you've been in downside risk contracts since 2012, 13, 14 with Medicare. Now they're really just becoming more popular, and we can talk through that as well as we're going. I'll kind of pause there. Any questions so far? Going a little fast. Okay. So these are different alignment models that we're seeing a lot of health systems and physicians work together on when you're talking about alignment, when you're talking about collaboration, cooperation. And the health system executives that I speak to, they're acknowledging they can't pay or they can't employ all physicians. The physicians that I'm talking to, some of which don't want to be employed, appreciate their autonomy. So where is the intersection for these two organizations, or at least these two stakeholders? And this is really the intersection and the gravity of integration that I'm seeing occur. Anything from medical directorships to gain sharing, maybe partnering on 1 or 2 bundle payment contracts. You're seeing clinical integrated networks, which we're going to talk about in a second. That's certainly driving and aligning incentives, but really could just be a legal entity that's taking value-based contracts and shifting them down or rewarding the physicians that are within them. That's a way to do that. Accountable care organizations, you're seeing co-managements, joint ventures, and then all the way up into employment. Incentives are changing, right? The work RVU productivity model of employment, that traditional model, is starting to evaporate, right? It's maybe 90 to 100% of what you were getting paid as a physician in the past if you are employed. That's shifting down to 70, 60, 50, maybe even 40% of your overall payment. The difference is being made up by outcomes. And we could all argue about what are outcomes, who drives those outcomes, why do those outcomes occur. So there's a lot of confusion, and certainly the way people, providers, health systems are all getting paid, and I think everybody's trying to find the silver bullet. If you can come up with the silver bullet, you'll probably do pretty well, but no one has so far. So again, these are all innovation pilot projects that are going on in healthcare, and we'll talk through some of those. So I'm going to go deep into clinically integrated networks. Any questions on any of the other ones? Before.
Enterprise is professional services.
Yeah, it's basically a larger physician organization that's owned by the health system that includes some independent physicians as well, that are just signed into maybe either one facility that they're going to work at, or part of their payment is paid for through the health system, other is through just independent contracts that they have. The word that a lot of consultants use a lot is value, right? And value, the definition of value is in the eye of the beholder. But I think when I'm talking about value, this is how I define it: quality and service over cost. You heard patient satisfaction be mentioned over the course of the last 2 hours. A lot of disagreement in why patient satisfaction drives your income. Unfortunately, it's a big part of it. And until that changes, that's something that is continuing to be a driver within CMS, and certainly a lot of the commercials are driving that as well. Again, it's hard to really pinpoint where or how you define value, and certainly we're having stakeholders outside of physicians and health systems define what value is, and I think that's the rub. And I think that these clinical integrated networks that I'm going over shortly, that creates leverage with size. And I think that once you do that, once you're creating that size, and once you're partnering across the continuum, you're starting to drive change at a very large level. And I think that's important. You can't just improve or reduce cost. You can't just improve quality. You have to do both. And that's the challenge that a lot of physicians and health systems are going through. So now we're going to talk about clinical integrated networks. A clinical integrated network is just a large partnership between health systems, physicians, and other providers to improve quality, reduce cost, and then get rewarded for that, and then distribute those rewards to the stakeholders that, in theory, made the most impact. And so that's really the quick and dirty definition. Getting other providers in your network is a priority for a lot of the health systems that we're talking to. So you've got independent physicians that are within the clinical integrated network, some of which are just doing that to get value-based incentive payments, right? Others are doing it for economies of scale. They're able to subsidize their IT costs. That's an important aspect. Some individuals are just getting into these organizations for access to patients, because if they're not in one of those, they're not getting access to the patients. Others are in it for access to data. They want to be able to challenge what data is out there, and they want the resources to do that. I always say when I'm working with health systems and physicians is it's not. There are discussions about poor performing physicians. I can't tell you how many times that the poor performing physician would come into the room and they were defined as poor performing because they didn't even know the metrics that were being tracked on them. So it's getting that information out, it's bringing stakeholders into the discussion, and then allowing the physicians to lead those initiatives. Now, we all know physicians are extremely busy. And unfortunately, it seems like they're being taken away from patient care with the electronic health record, with other meetings that they need to go to, leadership discussions that they're involved in. And so just making sure that the value's there and then they're getting compensated for that is certainly important. Any questions on the definition there? Any questions on the reason why these organizations exist? Okay, great. So then there's the clinically integrated networks need to provide value in the terms of monetary value to the stakeholders that are in their networks. That's a major aspect of what value they're providing. Otherwise, they're just a shell organization that's maybe sending out some educational events every now and then. This is the maturity model of contracts that I'm seeing signed throughout the clinical integrated networks. The first is called a hospital efficiency program, or otherwise known as a hospital quality and efficiency program. Anyone in this room ever heard of that term before? Okay, so really all it is a contract between the health system and the clinical integrated network. Okay, both of which are trying to improve quality, reduce cost, and then get paid for that. Right? The health system has all the data. It's typically inpatient based. And it's either looking at supply costs, it's looking at Medicare quality metrics that the health system's getting penalized on, and bringing the physicians, bringing the clinical integrated network into the fold and saying, hey, we've got $20 million at risk with Medicare, where we've got 17 different vendors in orthopedics. Bring in the orthopedic surgeons, bring in the primary care, bring in other physicians, and say, hey, as a health system, as a physician group, can you help us reduce the cost while keeping quality or maintaining or improving quality? That's really the initiative. No metrics are selected if the physicians don't agree with them. No cost savings situations occur if the health system isn't okay with it. And then really it's just a shared savings model from there. And that's a starting point. It's all it is a starting point, because there is an end game right there, right? You can only get so much cost. You can only change the outcome so much, at least on that inpatient level. But what it does is it gives you a pilot program to say, hey, with this group of physicians, with this health system, we were able to do X. You take that pilot program out, you go out to the market. You go to your payers, you go to your employers, and certainly others, and then you have those discussions around, okay, how do we create the employee-sponsored health plan? How do we reduce costs within our employees while keeping quality at a priority, certainly? Medicare Advantage, we'll get into some of that in a second. but certainly that's a big aspect, and certainly there's a lot of growth with Medicare Advantage on that. Medicare commercial shared savings. We heard accountable care organizations be mentioned a number of times. Looking at the Medicare beneficiaries in your certain community, reducing the spend on them, improving the quality across the metrics that CMS creates, and then getting paid for that. Again, these are pilot programs, these are drivers, all focused on one goal, is reducing the overall healthcare spend while maintaining or improving the quality to the patients. Any questions on these or how health systems or clinical integrated networks go through this maturity? Great. Clinical integration requires provider-driven commitment. Physician leadership across all aspects of the integrated network. If a clinically integrated network creates a strategy or signs a contract that is against the physicians that are within the clinical integrated network, everyone loses in that scenario. Which is why the physicians need to be at the table, they need to be leading it, and they need to be compensated appropriately for that effort. When you have that scenario occurring, clinical integrated networks typically do pretty well. When you have side conversations within the health system occurring or individuals that are not driving patient outcomes, that's when you run into trouble. A high degree of interdependence and cooperation, and certainly a defined work plan is a priority there. We need to see where you're going and what future state we're trying to build. So from 1996, which is really the first defined clinical integrated network definition by the FTC, to about 2018, a lot of health systems, a lot of physician groups have created these clinical integrated networks. They've created the legal entities. They've spent amount of time, resources, technology creating these clinical integrated networks. Now what we're seeing is these organizations try and optimize the value that they're providing to their stakeholders. Whether it's IT, whether it's education, whether it's the ability to participate in alternative payment models, the APM 5% bump, which we'll go through in a second, but access that, or if it's the ability to improve their performance across what you heard, the merit-based, the MIPS, which is really a zero-sum game. So if you're gaining in MIPS, your competition is losing. And so there's other ways of going about that. These are other ways of looking at that. And certainly network adequacy is a major aspect of that. You need to have the right providers in. And there are organizations that are going through that with data, maybe incomplete, that they're using to select. Value proposition for clinical integrated networks. Combination, I'll start in the middle. Access to patients. Technology, interoperability. So not everyone is on the same electronic health record, medical record. There's a lot of technology out there that's connecting those systems, that's taking claims information and then looking at it from both a clinical perspective, also from just a solidifying gap perspective, and defining quality across those key areas, and then looking at what I talked about a moment ago in terms of enhancing reimbursement around the MIP, APM, value-based care contracts that they're signing. Specialists within these clinical integrated networks, yeah, they might get a few distributions throughout the year from the contracts, but really it's the referrals that are being generated from the in-network aspect of a clinically integrated network. That's really the value there, and certainly participation in the bundled payment area. Primary care, supporting on care management. A lot of the dollars for value-based care initiatives, shared savings, are being driven certainly to them. Coding and documentation support is a major aspect. Coding and documentation doesn't impact you just on the revenue side of things. Coding and documentation can impact you also on what your quality looks like. So a lot of organizations have adopted new electronic health records. Data supports that when you're adopting these new electronic health records, your quality reduces. It's not that, well, it could be because maybe you're spending more time on the electronic health record, you're losing productivity, and you're not dealing with the patients. But what we're seeing is that everything is not captured appropriately in the new electronic health record, which is then shifting the quality metrics attributed to your physicians, which is then hurting the revenue, not only the revenue side, but also your reputation in the market. So this is a very important aspect of something that I think everybody just needs assistance on in terms of making sure that coding and documentation is accurate. No one's overcoding, undercoding, it's just accurate. We were at a health system a few months ago that just adopted a electronic health record. I won't tell you what it was, but they customized it, and by mistake, the electronic health record only caught the first 4 codes. So the physicians and the nurses were inputting the codes, but anything after the first 4 weren't captured within the electronic health record. That made a huge issue on quality and the revenue that was generated for the first 2-3 months of that adoption of that electronic health record. Major implications on that. And when you're dealing with a health system that has a 1 to 2 to 3% margin, that makes a huge difference. I worked as a third-party consultant for HCA. So we went into every one of their markets and told them if this market's ready for a clinical integrated network or if this market's not ready for a clinical integrated market. They honestly, if you're just talking about HCA, and this is, I guess this is actually I think this is more than 4 years ago. If you're just talking about HCA, they put CINs in a very few amount of their markets. They're driving volume. And they're making sure that their publicly available data supports the outcomes that the patients are looking at, and it's a prerequisite to going to their facilities. So HCA has again developed a few of these, and they're actually starting to grow more, and they're starting to do it within the concept of those bottom 2, that hospital efficiency concept. Let's mess with margin a little bit. Let's try to get the expenses less. So let's look at supply costs. Let's look at what we're spending our money on, and then the employees that work for HCA. That's an opportunity for them as well. So they're looking at that too. So again, they're typically publicly available. And then if you see any titles like VP of System Integration, they're typically in charge of that. Population Health is another word for it. VP of Value-Based Care. So there's ways to look at that and to see if there's an opportunity, but there's over 400 clinically integrated networks that span really the overall geography of the U.S. So there's a good chance that if you're in a market and you don't think there are CIN, there's probably a CIN you could join. Is it offering the most amount of value? That's the question that you'll have to ask. All right, so consider a service line approach to the CIN. I apologize that this is a little, the text is tiny, but if the results are market quality and financial, so market is market performance. Are you the system leader? Are you the market leader? Quality, I think we can discuss what quality is, but certainly you want to be a high quality provider regardless of how you define it. And then financial, you want to be affordable. You see that through the middle, you can see some service lines. Again, not all are there, but those are some areas that people are looking at. Some CIN initiatives that are going on to kind of go at or improve those service lines, and you could kind of go from the bottom up or top down, either identifying frequent flyers, defining preferred post-acute providers. That's a big area to reduce readmissions. I worked for a provider in Columbus, which I have a case study on today, and they went through a large exercise to create the top 10 post-acute providers that they wanted to send their patients to. Now everybody has that, right? But this was in about 2011 or 12. So they started sending those patients to those providers. All right, they just created their clinical integrated network, haven't signed an agreement with the post-acute providers at all. They were just focused on their physicians, getting the physicians into their network, right? So they didn't really focus on the post-acute providers. Well, this health system, what they realized was It was kind of a McDonald's, Burger King approach. So McDonald's kind of does all the market research, puts their M on one corner, and Burger King goes right across the street, doesn't do any market research, just goes across the street. That's what was happening with this health system and this CIN. They were sending all their patients to the right post-acute providers that had the high quality, low cost. Well, the competition found out who those post-acute providers were. They started sending their patients there, and all of a sudden, the health system that did all the work wasn't getting the beds that they needed with the appropriate post-acute providers. So now, all of a sudden, they're bringing the post-acute providers into the clinically integrated network. So it's now not just physicians, not just health system, now it's post-acute providers. So it's those kind of strategies that as you're creating, you're thinking about your competition, and certainly there are areas that you want to win, and there are also areas that you want to make sure that you're tied in or partnered with the right individuals. Does that make sense? Great. So then you've got become involved in bundled payments, which we went over just a second ago. You've got the supply cost management, certainly in primary care, chronic disease management, and then refer to high quality, low cost providers. Just some initiatives that are being done. These are other strategies that you're seeing. So clinical integrated networks that have just been created are really looking at educating on just the reform that's going on, how that's impacting them. You're looking at coding documentation if you're reading from left to right here. And then the contracting, they're typically looking at the employee health plan, like I said, hospital efficiency, and Medicare Advantage. Once they've created those wins there and the value there, they'll go to the strategic ones. So now you're seeing telehealth, virtual health, chronic care management. How are they getting to those high-risk patients or those patients that have multiple comorbidities? Interoperability on the IT side. They're maybe adopting those patient registries. They're trying to manage quality metrics, whether it's the ACO, the MSSP, the Medicare Shared Savings 31 quality metrics. Maybe they're just trying to manage those. So they need to get a patient registry to do that at an affordable rate, because those could be expensive. And the transformational call coverage, ED management, access to regional partners, post-acute management, et cetera. So these are just, again, other tactical ways clinical integrated networks are making a shift in their communities. Then we're seeing, with the discussion around the Cleveland Clinic, these super CINs. And really, it's multiple clinical integrated networks wanting to gain additional leverage, additional economies of scale, and linking up with each other because they've maximized the value that they can grab in their own unique communities. It is a volume game. This is when it turns into a volume game. The advantages and disadvantages of regional clinical integrated networks are the access to infrastructure, diffusion of risk, maybe even network adequacy. But the disadvantages are if a clinical integrated network links up with another clinical integrated network that isn't at the same maturity level that they are, it's going to create significant challenges. So perfect example is if you're going to provide care to an employer, and let's just keep with the Ohio example, that services or has employees in Cleveland and then 2 hours south in Columbus. Your Columbus CIN can't track quality as well as the Cleveland CIN. Obvious limitations with how you're going to negotiate value-based contracts. You just need to be at the same level. And it's really, you're only as good as your slowest input in a lot of these contracts. So if your slowest input is either a feed from another provider or it's network adequacy limitations, those are just things you just need to be cognizant of. So Mount Carmel, which is in Columbus, I guess that kind of gives away the client that I had a number of years ago with the post-acute challenge. We created a clinical integrated network for them in 2010. They had a messenger model, PHO, Physician Hospital Organization. Everybody understand kind of what a PHO is? it basically connects the providers to kind of single signature contracts that in theory would get them better rates than they would have by themselves. But they transitioned that PHO into a clinical integrated network, which meant that they can sit and negotiate value-based contracts and rates. That's really the value of a clinical integrated network. We can say, the network can say, look, you're paying us 120% of Medicare. Our providers are worth 122% of Medicare. This is why. And that's kind of our negotiation. Now, there are varying degrees of that negotiation that I'm going to be going over in the next session, but that's really what they did. And so since 2010, they've gained about 200,000 value-based care covered lives. Again, like what I said, they transitioned the messenger model. Their primary focus, at least initially, was pay for performance. Payers were willing to say, hey, if you did X, you get Y. Very similar to a fee-for-service, but on that bonus level. They then they had a Medicare Advantage plan called Medigold. They used that as a pilot covered life strategy where they were seeing where they can move the dial on certain metrics. This was a market that all the providers didn't have the same EMR, but since they owned the payer, they had all the information. So that's how you can kind of get around not having the same electronic health record. Now that's obviously a unique situation, but if you're creating or negotiating contracts with third-party payers, you want to get that information in a timely fashion. And then they contracted with Medicare and Medicaid throughout the years as well. And you could see their covered life distribution across commercial, Medicare Advantage, Medicare fee-for-service, and then Medicaid as well. Any questions on this case study? Okay. One other case study. How are we doing on time? All right. So this is Ochsner. So we spent about a year working for Ochsner Health System in New Orleans. They created a clinical integrated network, but they wanted to turn it into a regional clinical integrated network. So what they ended up doing is a two-pronged approach to linking in with the regional partners. Lafayette was a significant one of them, and a number of other ones across the state that they were looking to contract with. And they sat down with the potential partners and they said, look, we will help give you access to more value-based contracts, point one, and we will also offer some solutions that we've created on our side to your providers and to your physicians at either a reduced rate or free. And so a number of these health systems, 6 to be exact, signed up, 5 CINs, over 2,400 physicians. And from 2015, their first goal was just to align governance, communication channels. 2016, let's get everybody linked up. They bought a patient registry. They started linking up from the different EMRs to get the data, to understand where they were, realizing that the data was never going to be perfect. They wanted to use it as a compass. And certainly the real-time aspect of that wasn't real-time. It was weekly or in some cases monthly. But that was just a way that they were able to drive or at least start understanding the patients and who's coming to their facilities on the regional level. Then they entered into multiple downside and upside risk contracts. But what they did was, for the downside contracts, they only used Ochsner's large employed physician group. So they leveraged that employed physician group and then used the upside contracts for the regional players. And that was a value proposition that they gave a lot of the hospital partners that were either rural or in less urban than New Orleans. And that was a big aspect. Now, if you remember, Ochsner, after I think Hurricane Katrina, they acquired a lot of tenant hospitals that were abandoned during that. Well, not abandoned, but were basically sold for almost nothing. And so almost overnight, Ochsner had to deal with, they went from a large academic/employed physician organization to trying to figure out ways to link up with their independent physicians in these new facilities that they just acquired. This was also another strategy to do that. So if you were going beyond past 2015 to 14, 13, et cetera, that's where they were. Any questions on this case study? Are these case studies helpful to kind of understand how people are using these clinical integrated networks? And because I've got a few more, I can go through them quickly or slowly. Great. So before we break, clinical integrated networks, lessons learned, keep it simple and transparent. That number one bullet is probably the most important. You can get very complex with clinical integrated networks, with quality, with how you define it. The goal here is to keep it simple because all the stakeholders, whether it's the physicians, whether it's the health system, the post-acute, they're very busy. You only could really spend a select amount of time on initiatives like this, and certainly the transparent aspect. We're all trying to do the same thing. Place physicians into positions of leadership, align metrics across value-based contracts. So I've gone into networks that had different diabetes metrics, different heart failure metrics. That's a disaster. Even if you get the same metrics across the contracts, your baselines are going to be different because it's different populations that you're dealing with. So even if you align the metrics across your commercial contracts, you're still dealing with some complexity because the baselines and the targets are going to be different and the payout schedules are going to be different. So making sure you align your metrics is a very important aspect of this. CINs is only as strong as their slowest adopter. Mentioned that in the case study. Allows CIN vision to drive your IT strategy. Too many times is it the other way around, and those are very expensive mistakes. And then stick to the basics. Gaps in care strategies. Those all you need are claims level information. There are solutions out there that can do that very effectively. That's an important aspect. Certainly it limits your upside there, but creates a different revenue stream for both the physicians and the health system, create preferred post-acute partners, implement guidelines across medication reconciliation and compliance, and then work on acute coding and documentation practices. So these are just the quick lessons learned from the CIN part of the discussion. I'll pause here. We got a break, and then I'm going to be going over the value-based care strategies. But any questions on at least the CIN general kind of makeup, their strategies that they implement, and the value that they're adding?